So, K2. I published a video on K2 recently and was very surprised about the amount of reaction I got to it. Bart Robinson shared a lot of questions. Angie Stone and Saul Miller Smith talked about, shared some of their own stories. Ken Rosh, Have Faith, several, Bambi Abel, all made comments. So again, a lot of interest and excitement about this area. And it's like, duh, I should have realized that. All you have to do is Google K2, removal of calcium from plaque, get healthy. That assumption actually seems to filter the internet, and it's clearly the assumption that the K2 encouragement is built on. Everybody's saying take K2, get that calcium out of your arteries, your plaques. Well, it makes sense. Everybody knows that the higher your calcium score, your Agatston score on a coronary artery calcium study, the more risk you have for heart attack and stroke. Well, most everybody knows that, and that is the case. However, what's interesting is within the Bale-Duneen community, and clearly I've seen this with years of practice in this area. When someone has a plaque, what we're looking to do is, number one, see whether it's inflamed, soft, liquid, and you can see that. If it is, we want to slow it down. And in fact, the way we know we're slowing it down is that we increase the calcium in that plaque. You start seeing flecks of calcium. So it does appear that there is, and you see this, you look it up in the internet, you see plenty of research around this area, that you get progression from soft inflamed plaque to calcified or hard plaque, what we call echogenic plaque. That does represent increasing stability. So in this series of comments, John Lorscheider, as he often does, brought up some great articles. It's interesting, John, I was in a restaurant when I first saw your post. I was able to read that article at that point. But now, when I go to look it up for this video, here's what I get. I can't find the article. I'll describe it, though. Basically, this was the researchers in John's citation took actual plaques. Their assumption was plaque is like mortar. It creates, calcium is like mortar within the plaque. Calcium, therefore, increases the strength of the plaque and keeps it from rupturing. And obviously, plaque rupture is the problem. Now, I've actually seen other studies where they assumed that that calcium in the plaque was bad. They actually got a few dozen plaques from a path lab, a military path lab, and looked at it. They were surprised to find their assumption wrong. In fact, in their study, they saw no impact on the strength of the plaque from calcium. However, what they saw was the more soft lipid cholesterol you had in the plaque, the weaker the plaque. So again, although they were surprised on their assumption, what they found didn't surprise me. It's soft plaque, soft cholesterol, soft fatty tissue that is creating weakness. We want to get that out of there. In fact, you'll see several other studies where folks that don't get into this whole inflammation thing just say, you know what, we know that that statins are increasing the strength of plaques, and we think that it's happening by pulling the fat out of the plaque. I'm not going to argue or quibble over what the actual mechanism is. I do know that, again, time and time again, what we want to do is progress from a soft plaque to hard plaque, stable plaque. Now, Mike Geiso brought up a good point, and if you start looking in the literature, you'll see there's actual literature showing that decreasing the density of coronary plaque can actually increase the risk for a heart attack. In other words, maybe some far more direct evidence that pulling plaque out of pulling calcium, I keep doing that. I keep saying plaque when I mean to say calcium. Pulling more direct evidence that pulling calcium out of a plaque in an artery can actually be dangerous. So let's go through. This was from the MESA study. MESA study was very, very well known. Has to do with the Agatston score and coronary artery calcification. So this was a nested study within that group. So here's a couple of the quotes out of it. The title: the denser the coronary plaque, the lower the coronary vascular disease risk. MESA analysis shows the CAC density component of the Agatston score is an especially important predictor. Our new conclusion is not only that density is protective at any given level, but even if you have a lot of coronary artery calcium, it's better to have it all calcified. These findings suggest coronary artery calcium density values should be especially useful to determine preventive therapy for patients at an intermittent risk. The density score, if it is low, pushes you towards aggressive treatment, and if it's high, tells you to back off. And that's exactly the way we've been practicing for years. Now, here's the actual citation in the study. JACC, Journal of the American College of Cardiology, 2017, October. Coronary artery calcium volume and density, potential interactions, and overall predictive value. The multi-ethnic study of atherosclerosis, that's MESA. So the results were, during a 11-year follow-up, there were 390 cardiovascular events, 264 which were in the coronary artery, others which were outside of the coronary artery. With each standard deviation of coronary artery calcium volume, the risk increased by 0.73. Risk of cardiovascular increased 0.61. Conversely, each standard increase of coronary artery calcium density was associated with 28% lower risk. Now, the probability, according to them, of finding this was less than 1 in 1,000. In other words, yes, you do get, and here's part of the contrast, the enigma, the logical frustration that I go through with my patients quite a bit. Yes, on the one hand, we're wanting to slow down inflamed plaque. We want it, and the way we know that we're doing that is we're seeing calcification. Now, why on earth then does an increased calcium score on a coronary artery calcium scan show increased risk? Because it shows that you've gone through this cycle many, many times of laying down inflamed plaque and then starting to back off from the inflammatory period, and your body's starting to heal it. As your body heals it, it's increasing the calcium density. And again, here you see it with the MESA analysis. In other words, yes, increased volume of calcium does correlate with increased risk. However, increased density correlates with decreased risk. Again, very consistent with what we've been practicing and what we've been seeing as we practice in terms of that progression towards plaque stability. This may have gotten confusing However, I don't think there's any confusion at all to the question, do you really want to take all of the calcium out of your plaque if you have it? I think there's plenty of evidence that that might not be the right thing to do. Thank you.